Good evening, everybody. This is it's my great pleasure to participate in this webinar series about laparoscopic versus robotic fluorescence guided surgery. We're going to have a discussion. We have two great panelists. This is a webinar sponsored by the International Society of Fluorescent Guided Surgery. We're going to have Dr. Emanuele Menzo, who is a vice chairman of the Department of Surgery at Cleveland Clinic in Florida. He's also associate program director of the General Surgery Residency Program at the Cleveland Clinic in Florida. He's a professor of surgery from Florida Atlantic University College of Surgery, and also professor at the Florida International University College of Surgery or Medicine. He will be talking about the laparoscopic use of ICG. And we have also Dr. Carlos Galvani. He's a professor of surgery at Tulane University, and he's the chief of MIS Bariatrics at Tulane University Hospital. My name, I'm Omar Bellorin. I am associate program director of the General Surgery Residency and assistant professor of surgery at Weill Cornell New York Presbyterian Hospital in New York. And we're going to start, this is going to be more like a discussion. Dr. Lomenzo will start a presentation regarding laparoscopic use of ICG during his experience, and then we're going to give the word to Dr. Galvani to talk about robotics. And then at the end, we're going to have 10 to 15 minutes of Q&A discussion. You are welcome to use the chat to send your questions, and we're more than happy to bring them up and start a really nice discussion. Emanuele, Dr. Lomenzo, nice to see you, and happy to have you, and please, whenever you're ready.
Thank you, Omar, for the nice introduction and for the invitation to participate to this roundtable. I'm going to share my screen, and I'm going to give you the perspective of the laparoscopy use of ICG. And can you see my screen?
Yes, I can.
Perfect. So just as a disclosure, I'm part of the advisory board member for the Diagnostic Green, which is a producer of ICG. This will have no impact on today's presentation, but that tells you my passion and involvement in the field of fluorescence-guided surgery. Not that I have to really tell this audience about ICG or fluorescence-guided surgery, but just as a background, as surgeons, we rely on the ability to see and feel tissues. However, the appearance can be deceiving, number one. And number two, when we talk about doing MIS procedures, either laparoscopic or robotics, that feeling of the tissues is, of course, lost. So that's where we can use additional ways to visualize and recognize structures. And we basically use and benefit from the injections of substances called fluorophores that have the property of emitting energy of a different wavelength that they are actually excited with. And that allows us intraoperatively in real time to identify those structures where the fluorophores are. Because of, in order to avoid the background noise, we try to excite these molecules in the NIR spectrum of light. ICG is the most commonly used dyed. The reason it's most commonly used because it binds strongly to the plasma proteins, can be eliminated, actually is eliminated only by the liver and the bile. And it's as minimal, if any, reactions and side effects at 0.05%. And as other fluorophores absorbs at one light wave and then emits at a different one. The current applications are based on the identification of the anatomy, perfusion, and tumor identification. Of course, for each one of them, there's specific applications: anatomy identification in the endocrine glands, the biliary tree. My apologies, my slides are advancing automatically. The lymphatics, the ureters. When it comes to perfusion, we talk about not only the anastomotic perfusion, but also cardiovascular evaluation, transplant perfusion, skin and soft tissues, and of course the tumors. In general surgery, which is where we're going to be focusing tonight, the ICG or fluorescence guided surgery has been utilized in all these fields that are mentioned here. And of course, we're going to focus on what we do in practice in laparoscopy. So mostly foregut, bariatrics, some hepatobiliary and endocrine surgery. So we start with the most commonly used application, which is in the biliary tree and cholecystectomy. We all know the reasons for bile duct injury, anatomical variations, inflammatory changes, and also surgeons' experience in recognizing the anatomy. The fact that we lack the tactile sensation and the visual misperceptions can lead to the bile duct injuries, the majority of which are from misidentification. So if we can provide a way to really identify and look at these structures in a better way, we potentially can decrease the injuries. And that comes to our multi-center trial that was led by Fernando Deep, a researcher from Argentina that came to spend time with us here at the Cleveland Clinic. And along with my chairman, Dr. Raul Rosenthal, created and put together this international trial of over 600 subjects. So this was prospective, divided and prospectively randomized between white and ICG cholangiography cholecystectomy. And we had demonstrated that there was definitely a higher visualization of both extrahepatic and intrahepatic bile ducts, no adverse reactions and no bile duct injuries in the ICG group, as opposed to one injury in the non-ICG group. And these are the advantages of doing and using this technique. It's feasible, it's cheap. One vial of ICG costs about $8 or $20, depending on what your contract is. The system has already the light predisposed to it. So every laparoscopic equipment now is predisposed already with this type of light. It's very specific, is easy to teach, and their learning curve is basically minimal, if any. We're not exposing anybody to radiation by doing cholangiograms, and we can still continue to operate under these lights and don't have to stop the operation to visualize the structures. I'm going to run through this video real quick just to give you an understanding of how this is utilized in our practice. This is a patient that had a percutaneous cholecystostomy drain put in before and because of acute cholecystitis with delayed presentation. And as you can see, the gallbladder is very contracted, and we already expect some difficulties identifying this gallbladder intraoperatively in the structures. With the usual approach to gallbladder surgery, we start the operation. And as you can see right away, ICG allows us at least to have an idea between the scarred tissue where the main structures are. So that will allow confidence in dissecting the tissues, and slowly but with safety, we can identify all the structures and continue to work with the ICG lights on. We keep toggling back and forth because, again, this is the main advantage. That gives us the understanding of where the important structures are. We're clipping what appear to be the artery, but again, the gallbladder is very, very contracted. You can see here the underneath the liver. The usual identification of the structures with the view of safety and the critical view are somewhat difficult. We then found our cholecystostomy tube. we're approaching it from top down. But again, the toggling of the light allows us to confidently see where the main structures are and avoid damage. If we switch gears, another application in our practice is in esophageal surgery. There are four main applications: tumor identification, which has not been proven 100%, lymph node mapping, thoracic duct identification, and then perfusion assessment to reduce leaks. For tumor identification, the ICG is injected preoperatively, endoscopically around the tumor itself in the four quadrants in the submucosa. The 20 minutes later, the visualization can be done. And the second type of use of the ICG is peritumoral injection to identify the lymph node and the lymphatic drainage. These allow for an increased number of lymph nodes that can be harvested during the procedure. As you all know, the goal is to achieve at least 15 lymph nodes dissected and resected during the procedure. If we inject ICG and albumin, we increase the visualization by 60% because of the tighter bond of ICG to albumin and to proteins in the plasma. You can see the difference here between the white light and the ICG light, where you can see exactly where the lymphatics are, not only the lymph nodes, but also the lymphatic vessels. Thoracic duct, obviously we're talking about Ivor-Lewis type of esophagectomies. The thoracic duct injury remains a significant source of morbidity, but also mortality in some of the patients. This identification can be easily achieved by subcutaneous administration of ICG, either in between the toes preoperatively or by the inguinal lymph nodes. Or there's a more recent description of injecting into the mesentery of the small bowel at the time of the abdominal portion of this operation. And finally, obviously, anastomotic leaks that are the majority source of morbidity and mortality after esophagectomy. The viability assessment can be identified not only by visualizing the color, but also the perfusion with ICG, not just the intensity of it, but also the speed at which the ICG reaches the esophagus and the gastric conduit. This is one of the studies. Obviously, this is open surgery where they measured the distance where the ICG was visualized, and they quantified and correlated the distance with the rate of leaks. But more importantly, by skipping this, it's actually the speed at which the ICG is visualized. And in this study, again from Japan, if the identification was within the 20 seconds of ICG visualization, the anastomosis was safe and there were no leaks. If it goes beyond the 30 seconds, the increased leakage led the surgeons to modify their technique and either proceed with further mobilization with cochlearization of the duodenum, or even alternative techniques of reconstruction. This is a short video of our technique for esophagectomy. Create the gastric conduit in a standard fashion laparoscopically. As soon as the conduit is made, we mark the area that will help us then identifying the perfusion. We inject ICG, and as you can see here, you have a quick and a good perfusion all the way proximally. And that will allow us to make the clinical decision of where to resect the conduit once it's in the chest. This is the thoracoscopic component. We divided the azygos veins. We prepared the esophagus. Here we're about to transect the esophagus. Again, we repeat the perfusion. Perfusion seems to be very good. You see how the venous lymphatics show up first, and then you have prompt identification of the esophageal stump and also of the gastric conduit up in the chest. Switching gears for the last portion of my presentations in bariatric surgery, obviously the concern that we have is leaks, especially after sleeve gastrectomy, and that's where the identification of the blood supply of the proximal sleeve in particular really is important. As previously described by other authors, the proximal blood supply of the sleeve is very variable, and the variability is what sometimes leads to the unexpected leaks, besides the distal stenosis and the other reasons that we all know. In CT scan study from Dr. Saber in New Jersey, the perfusion of the angle of His was significantly lower than in other parts of the stomach. That's why that is the critical portion that needs to be attentioned in case of sleeve gastrectomy. There's registries in different countries. This is the one from Europe, where all the ICG perfusion cases are collected. At the moment of this presentation, a few years ago, 129 cases were registered into this particular registry, and were divided in pre-anastomotic dosages and post-anastomotic dosages in an effort to understand if the surgeons changed their approach and what the results of that change was. 27% of the cases, the surgeon changed the approach and did the resection in a different way. In this particular study, where they use ICG to identify the blood supply of the proximal sleeve, they identified three types of patterns. The right-sided dominant, which is a safe dissection and that can be safely performed. The right-sided accessory, where there's an accessory vessel coming from the right side. The danger of ischemia comes from a full dissection of the hiatus, like in the case of an hiatal dissection, and cases of a left-sided accessory vessel in which there's danger of ischemia if we do the dissection too close to the angle of His. And that's why we try to save the fat pad next to the angle of His. In the interest of time, I'll stop here, but I'm happy to answer questions at the end of the seminar, and I'll stop sharing my screen.
Manny, thank you so much for an amazing presentation. We have Dr. Galvani from Tulane University. He's also chief of MIS in bariatrics. I'm sorry that I'm a little bit hoarse. Carlos, you can share your screen, and then we go on a Q&A at the end of your presentation.
Happy to be here. Let me go and share the slides. This is not a very complex presentation. I think there is a lot to be said and a lot to be done with this technology, mainly in the topic of bariatrics. So when I look at the indications for bariatrics, the use of ICG in bariatric surgery, and this is a systematic review where they found only 13 papers, of which 3 of them were only case reviews or case reports. So you can see the majority of the indications for ICG were perfusion. There were 2 manuscripts in this review that used the intraluminal ICG as a leak test, which is something new. I haven't seen it coming from laparoscopic surgeon, but in social media, a lot of robotic surgeons, at least in the groups that I belong to, have been posting videos on this. So we can discuss whether this is something that is useful or not. But when you look at the distribution from robotic to robotic versus laparoscopic surgery, you see that the majority of the cases were done in laparoscopic surgery. This is not a large number of cases by any means, but only 30 35% of surgeries were within this systematic review were done robotic. And those were mostly 75%, as you can see there, were for gastric bypass. So this is testing anastomosis, trying to prevent ischemia in the tissues and diagnose perfusion. So I think when we look at so right now, I think that the technology that we know the most in robotics is Da Vinci, and one of the things that I rescue, and that's why I think a lot of robotic surgeons are using this technology, even if they didn't plan for it at the beginning of the case, is because of the ease of use. You know, as simple as pressing a button. You can see it here on the screen, you turn it on, and then Firefly turns on. And of course, if you have asked your anesthesiologist to inject Firefly, the ICG to the patient ahead of time, and sometimes this is, you know, it could be a minute or two before you can see the images. So, you know, the ease of use, I think it has allowed a lot of surgeons that potentially sometimes didn't even have the intention to use it more. And you can see some of the images that you can appreciate here when you're creating anastomosis, in this case, after a gastric bypass. So, you know, I think for me, particularly has been the most use I have given this technology, the Firefly along with ICG. It has been in revisional bariatric surgery. You know, this is a complex revision, a patient that had a perforated marginal ulcer, taken care of with a next lab, and then recur the ulcer, and then refer to me from our state. So you can see, you know, this is an extremely difficult operation, and I'm not showing the whole lysis of adhesions from the beginning of the case, but you know, as we are deciding whether we're going to do an esophageal, a near esophageal or a total gastrectomy, you know, this is the time when I think we're going to end up using ICG in these cases. So you see the ulcers had perforated towards the back into the remnant stomach. So we're transecting the pouch, transecting the small bowel, and then deciding to do this near esophageal. So of course, we're going to try to use ICG in this case before doing the anastomosis. You know, I think I'm sparing the left gastrics in this case, but I still want to make sure that that we're seeing what we need to see. And you know, this is one of the drawbacks of this technology, particularly in the type of patients that we do, because sometimes even if you have given enough ICG to these patients, you won't see it due to the significant visceral fat that some of these patients have. So, you know, it lets you with a bitter taste in your mouth, just because you don't know if you're seeing what you need to see. And there's a lot of uncertainty with this. And this is the traditional leak test that I do, which is with the endoscope and filling up the abdominal cavity with water. So this is, you know, I wanted to bring up this intraluminal use of ICG, and you can see there some of the formulas that are recommended on how to use it. I personally have not had any experience with this, and you had what the amount should be used for sleeves, or recommended to be used for sleeves. But you know, the recommendation is subjective, because there is no objective evidence that a little less or little more is going to make much of a difference. And then you see the same for gastric bypass, and then you put it through a BCG or an autogastric tube of your choice. So here are some pictures that you can see, you know, of after a sleeve, and many people have seen leaks of ICG through the staple line, something that they have not seen before, using air and putting the sleeve underwater. You can see that little dot of ICG on the right side, on the right of the screen, something that you probably you want to see with your naked eye. So the big question is whether this would be something that is clinically relevant or not. And the same thing that you can see here, this is a picture from Sachin Kukreja on a patient that had a SADIS and he had a leakage of ICG in the posterior side of the anastomosis. So, my thoughts are, it seems like it's a little too sensitive for what we do. Whether there is a clinical correlation, if you leave this without doing anything or not, is questionable. And sometimes this could cause other problems because you're reinforcing a staple line that not only could have a vascular compromise, but it could have a stricture. So something that I always worry about. And then if we don't see this leak with insufflation, which is my preferred test, I had and I hope we can talk about this. When I see bubbles, then of course I oversaw the staple line, but this doesn't happen very often. I say, maybe 1 in 200 or 300 cases. So if you haven't seen this in the past, does it make sense to now bring it in and add another level of complexity to our cases? So something that I think we had to think about. So this is one of the examples, a gastric bypass done by one of my fellows, Hani Takla, that Hani uses this technology. So I wanted to show you a little bit of how it looks. This is a negative test. But again, we don't know the quantification of what is positive, what is negative. So there is no extravasation of ICG through the anastomosis. So you consider that to be a negative test. So this is the only study that I found on this, and Curtis Perry was one of the authors in here, where they compare patients that had, of course, this is a retrospective review, but they compare patients that had the traditional endoscopy with insufflation and putting the tissues underwater, as opposed to the intraluminal ICG, and you can see that they reported they had 3 false negatives in the endoscopy group, and then within a period of 3 to 5 days, patients develop a clinically significant leak, compared to the group in the intraluminal group, that they saw 1 or 2 leaks, and they were able to leaks of ICG, of course, and they were able to repair at the time, and these patients had no complications. So they reported very high sensitivity as well as a specificity for this test. So something that we have to determine whether there is something useful. So what I see, this is my before last slide. I think the safety profile is good for robotics. It's a real time intra-op assessment, like everything that we use with the robot, and I think it could get better and better. And it will be better with some of the newer technologies if we don't use any dye. So hopefully there could be an addition to this robot or a newer robot. So it's definitely reproducible. Anyone could do it, and it doesn't add much of an additional cost to robotics. As I mentioned earlier regarding bariatrics in robotics, and that will be for laparoscopic for that purpose, poorly penetrates tissue, and as you can see, that is in fat. And we don't have a standardized technique. People do it all different. There is no specific timing, and there is no specific dosage. And then, of course, the most important thing that I have taken is that there is no ICG quantification assessment. So I know there are some companies that are coming up with that technology. I think Stryker is one of those, but the utilization of this technique and how efficient it is to diagnose what we need to diagnose, whether it is perfusion or leaks, I think quantification will be great. And I hope that the artificial intelligence will give us some of that in the future. So in conclusion, if I can get to the conclusion. So I think ICG for the way it's used for perfusion is commonly used in general surgery a lot, more colorectal surgery probably, but it's not very much popular in bariatric surgery. And I think we need a standardization of the procedure. And objective quantification is still missing. intra-op ICG quantification could become more important with increasing impact of robotics and machine learning algorithms. I think that's something that is hopefully coming for image and video analysis. And intraluminal ECG needs to be studied to confirm its utility to prevent complications. Thank you so much.
Thank you, Carlos. This was amazing presentation. And you know, I'm gonna start the discussion with a basic and fundamental question that I would like to hear your opinion on each one of you. And it's regarding the actual molecule of ICG, which we know that it was FDA approved in 1959, if I'm not mistaken. And it took all these years to basically popularize in what we're doing here, minimally invasive surgery. Of course, it's because of the devices that are used to generate the near-infrared light. And I know that you guys have a lot of experience with ICG, and I just want to see how you recall. And number one, why do you think it lasted that long for this technology to just come out that is very popular now? We see it everywhere. We definitely have an international society now for ICG only for all the applications. And you know, Manny and Carlos, you know, in your experience, when you started seeing this happening and how the technology started to evolve, I want to know your opinion in that kind of fundamental question.
Well, Omar,
Go ahead, Manny.
my personal experience, as I briefly mentioned, started when Fernando Diep from Argentina came to Cleveland Clinic to spend a year helping us with the research. And he's the one that brought the idea to Raul Rosenthal's table, saying, you know, you want to look at this because this is going to be a game changer. And like Raul always says, is of all the things that has passed through his desk, this technology is the one that he really believed the most. And since then, there was an escalation of efforts from a clinical standpoint, from a writing standpoint, and from trials and so forth to popularize this technology. You know, let's not forget that to the Western world, this is a phenomenon that is maybe 10 years old or 7 years old. But in Japan, this technology has been used for much, much longer. You know, even in gallbladders, of course, as open surgeries first, and then evolved into the minimal invasive options. I don't have a good explanation why it's taking so long, and I truly believe that we're still scratching the surface. I can tell you that even within our institution, although there's evidence in every single specialty of the ability and the advantages of using this technology, you know, we go to different surgeons, ENT, gynecologists, transplant surgeons, you name it, with the technology in hand, and there's reluctancy in utilizing it. I'm not sure why. I think we're finally seeing some of the results, but it's taking a lot of effort. If you think about that, drugs that are on the market don't have to go through all this scrutiny to become suddenly very utilized once they are approved by the FDA and whatever not. For us, it's really a matter of showing our societies, within our societies, the advantages. And sooner or later, this is going to really come to the surface.
Yeah, I think in my mind, this technology is trying to find a niche. I think in some areas of general surgery, as Manny mentioned, like cancer, identification of lymph nodes and things like that. It has been a no-brainer. Colorectal surgery has been a no-brainer either. But in other areas, sometimes, as Manny well said, pushing the physicians to try to implement the technology. And I think, a lot of people are using it as, instead of using cholangiograms to do when they do cholecystectomies and things like that. So I think we don't know the full potential of this technology, and I think a lot of surgeons perceive it as had to get new equipment, you had to buy it's very inexpensive to buy the vials of ICG. But then what else? Most people that don't have it don't know exactly what they need in order to get it and things like that. So, I see a lot of potential in the future, but discovering some of these technologies that could do the same as ICG without the dye. I think I'm more excited about that than ICG itself.
Carlos, one question to you, and now going into robotic and laparoscopy. So, I know that you've been doing robotics ever since the robotic platform came out, and I'm not sure whether the Firefly component, was this something that was added after the boom of the ICG and laparoscopy, or was this, because as far as I know, this was always part of the the light source of the robot. I know now Stores, Stryker are the main ones for laparoscopy, but Da Vinci Intuitive just one company, but you have more experience, so I don't really know when you came to know about this thing.
So this technology became available in robotic surgery since the XI, and it's not from the very beginning of the XI. It was added to it. Now that the endoscope didn't have the capability, so this is the endoscope class that we have now. So it has evolved over time, but of course the technology as it was designed at the very beginning, it didn't exist. So this is more recent. XI has been around since 2014.
So in other words, basically the industry has been also evolving with the capacity to expand the use of this molecule, which, as you guys said, is very cheap. There is a mild component of possible adverse reactions, etc. So the other question is more into like the detail. Okay, so Manny, I see that you do esophagectomy, you check perfusion. Would you explain for us in the audience, specific dosage, timing? What do you do for gallbladders versus tissue, perfusion checking, etc.? What are sort of the things that you do? The same with the patient. Do you add this to the consent, or do we have to add this to the consent? I mean, it's like another medication that we're giving, which is FDA approved with minimum adverse effects.
Yeah, so as far as the consent portion of things, we still add it to the consent, but the reality is that this is an FDA approved medication. And, we don't add to the consent patient to give antibiotics, for instance.
Right.
We were very careful to do it during the trials, but the reality is that now, if we're in the middle of a case and we encounter small bowel ischemia, for instance, and we want to use it, of course, we didn't put in the consent, but we have no problem injecting ICG and evaluating for small bowel perfusion. So I don't think the consent is anymore a problem. The only issue is that depending on where you're practicing, and I know we have audience from all over the world, you know, there might not be an FDA approval for that specific indication of ICG in particular. So that's the only thing you have to be careful because you're doing using as off-label. As far as the dosages, you know, by convention and by based on previous studies, we started by using a weight-based dose of ICG. It was 0.05 milligrams per kilogram, and that's what we use for our randomized controlled trial. To learn over time that really smaller doses are necessary, and to avoid that background you know, interference in the case of gallbladder from the liver. And of course, you have to identify what you're using the ICG for. If it's for gallbladders, we now use half a cc of ICG. We try to do at least half an hour before, if not more, before the surgery to avoid the background noise. You know, our equipment is a lot more sophisticated, it's a lot more sensitive, so we want to get away from having the background noise. If we want to check for perfusion, the injection has to be done at the time of the perfusion evaluation. We usually use 3 cc's of ICG followed by 10 cc of saline flush. We turn the camera into the ICG mode, and then within a few seconds, we see the arterial phase, we see the venous phase, and so forth.
Carlos, in your experience?
You know, I think my experience is basically acute surgery assessment of bowel perfusion, such as patients with internal hernias and so forth. For the index cases, you know, as I show you, very rarely I use it in primary sleeves. I never use it in primary sleeves, rarely in primary bypass. I try to use it in patients that have a large paraesophageal hernia and we're making a pouch. So sometimes I use it in that particular case. And I have used it something that you know, I don't do it all the time, but it seems appealing to understand how high I'm going into the mediastinum and to be able to see the pulmonary veins, the inferior pulmonary veins. I think it's great. You know, it's something that I discovered because one of my fellows said, why don't we do it? And we tried it. And there was no real indication for it, but it really lightened up the whole mediastinum and seeing those veins and staying away from it. You know, it was something that I have done, you know, 2 or 3 times after that. So these are my main applications. I think as far as the dosage is not that much different than what Manny said. I had a question for Manny, if you don't mind, Omar. So, you know, I wanted to understand if you think, what do you think are the reasons why this is no more broadly used in general surgery?
Well, I think the problem that surgeons have, all of us, is that we're creature of habit. We resist change, you know, and sometimes there's pride that gets in the way. There's a misconception that this is an expensive technology. There's misconception that this is not going to add because, you know, when you have the difficult case, it's difficult, there's inflammation, you won't see it anyway. I think there's a little bit of a lack of standardizations of the techniques. And this is especially true for the perfusion. There's no really good method to quantify the perfusion. So there's still a lot of subjectivity. And we do know, for instance, for bowel ischemia, I use it routinely as well, like you do, but sometimes it's hard to tell because if it's venous congestion, you do have the first initial glowing of ICG, But is that good enough? Is that give you a good sense of safety that you can leave the valve behind and maybe not even planning on a second look? So I think there's a lot of reasons. Definitely more evidence is necessary, and better technology, more standardized quantification is necessary.
Great, that's a good that's a great point. Mania, you know, one question for you. Basically, you know, we know that the International Society for Fluorescent Guided Surgery is expanding. I have noticed that the amount of laparoscopic surgeon with comparison to the robotic surgeons, do you think that we're having like a dichotomy or something that we should be all together? This is my you know, my perspective just from the outside, because I see that robotic surgeons, they have, you know, we have all these, you know, also little small groups and all that. And, you know, I was asking some of my colleagues, yeah, I'm a robotic surgeon, but, you know, I'm not sure if this is a USA phenomenon, but one of the ideas is, you know, bringing robotics and laparoscopic is basically to combine the efforts to use the both platforms towards, you know, the same common goal, which is basically expanding the voice with the use of ICG. Do you think that there is a disconnect on robotics versus laparoscopic surgeons? Do we know that we both are using the same molecule, or it's just, or maybe I'm just, you know, thinking this out loud?
Well, I think that for some reason, and I don't know where this is coming from. I don't know if it's social media initiated, if it's industry initiated, if it's administration initiated, or egocentric initiated from the surgeon. There seems to be somewhat of two different parties. Either you're on the robotic arm or you're not.
That's right.
And I don't quite understand that. I mean, in full disclosure, I don't do robotics, but I don't do robotics not necessarily because I don't believe in it. It's because my local situation, my type of practice, you know, at the moment, it will be very challenging for me to try to get into the learning curve. And for most of the procedures that I do, I don't quite see an advantage. Having said that, many of my partners do robotic surgery, but I don't consider myself a laparoscopic surgeons, and my colleagues robotic surgeons. We're all surgeons that use minimally invasive techniques. Whether they use a console to accomplish and finish the case, or I use my hands, as long as the results are within what's acceptable, I don't think any of the quote-unquote robotic surgeons are purely robotic surgeons. They're minimally invasive surgeons. They started by doing laparoscopy first. So I don't, and of course, when we talk about using ICG, there shouldn't be any difference either. It's just an axis. It's like if I use 3 trocars or you use 5 trocars, it's not like I'm a 3 trocar surgeon, you're a 5 trocar surgeon. So that's why there shouldn't be this distinction. If somebody believes that in their hands, the robotic platform gives better results, hey, listen, as long as the patient is safe, all the other discussions, the costs and everything else, we can argue until the end of times. But if the patient does okay, by any means, use the robot.
Carlos, any comments?
Yeah, I would agree with that. Yeah, I would agree with that. You know, I think I was a little pushed back by the robotic versus laparoscopic title of the talk, but because that's very common that we put one technology versus the other one. But I think as far as this is concerned, I think we should try to add people to it and multiply as opposed to divide. Because I think this technology has a ton of potential. Even newer applications, whether the intraluminal way of using it is something that is not, exploring new applications, right? So people come up with new ideas, and I think we have to explore them. I think that's how discovery takes place.
Yeah, I agree 100%. I think, I hope these webinars help also to integrate what you guys clearly say. There are different tools to perform surgery, and as long as we are safe and we have good results, then you use the tool that you think is more convenient for you and for the patient. I think we all have a common goal, and also that, like Carlos saying, the ICG application is we've just seen the surface of this. There's a lot to take, and there is much more of collaboration that we will have and we will see in the future. I don't know if there's any question in the panel and in the chat. I didn't see any questions. Elector, do you have your hand raised?
I'm sorry, repeat the question?
No, that you raised your hand. I don't know if somebody had a question on the chat, but I didn't see any.
No, there was nothing, no. I think everybody's, no one asked any additional questions.
All right, so thank you so much, Manny and Carlos, for this moment. Thank you, Electro, and thank you to the International Society for Fluorescence Guided Surgery for this space window. Looking forward for more collaboration, robotic, laparoscopic. We are all, same surgeons trying to find the same goal. I will say that more minds thinking towards the same goal is much better. Thank you so much. We learned a lot. I learned a lot, and have a good night, guys. Thank you.